All right, welcome back. Today we're going to jump into a topic that's a total classic for anyone on the GI wards or prepping for boards, achalasia. You know, it's one of those key motility disorders that you've absolutely got to know cold. So let's get right into it with the classic way these patients show up. So picture this. You're in clinic and your patient's main complaint is that they're having trouble swallowing. But here's the key, the absolute money detail. They tell you it's not just with solids like a piece of bread. It's with liquids too, even just a sip of water. Right away, that should be ringing some serious alarm bells for you that this is a motility problem, not just some simple blockage. And what's at the very top of that list? You got it, achalasia.
So what in the world is actually going on here? Well, at its core, achalasia is really a disease of two major failures. First, you've got the lower esophageal sphincter, the LES. That's the muscular ring at the very bottom of the esophagus. In achalasia, it just forgets how to relax. It stays clamped shut when it should be opening. And then, as if that's not bad enough, the second failure is that the smooth, wave-like muscle contractions that push food down, peristalsis, they're just gone. They've stopped working. So the food just gets stuck.
Okay, here's our game plan for this explainer. We'll start with what achalasia is, then walk through the diagnostic pathway. After that, we'll get into how we classify the different types, look at the treatment algorithm, and wrap up with the key takeaways you gotta remember. So let's really dig into those two key failures a little bit more.
I find it helpful to think of it this way. The LES is basically the door into the stomach, and in achalasia, that door is jammed shut. At the exact same time, peristalsis, which should be acting like a series of waves pushing everything down the esophageal highway, has completely shut down. So food and liquid just pile up, creating this huge traffic jam, and that's what gives patients that classic feeling of dysphagia. It's a real double whammy of dysfunction.
Okay, so you suspect it. How do we get from that suspicion to a rock-solid diagnosis? Let's talk about the diagnostic pathway.
Your first move is almost always going to be an upper endoscopy, or EGD. And the main reason you're doing this is to make sure there isn't a physical blockage, like a tumor at the GE junction that's just mimicking the symptoms. Next up, you might do a barium swallow, which can give you that textbook bird's beak sign. You'll see the dilated esophagus tapering down to a super tight LES. But the definitive gold standard can't argue with it test is high-resolution manometry. That's the one that actually measures the pressures inside and confirms both the failed LES relaxation and the absent peristalsis. It's the test that seals the deal.
And I have to circle back to that EGD for a second, because it is so critical for one major reason. You have got to rule out something called pseudoachalasia. This is a huge clinical pearl. If you have an older patient who comes in with brand new symptoms, we're talking less than 6 months, and especially if they've lost a lot of weight quickly, your suspicion for a cancer mimicking achalasia needs to be through the roof. It is an absolute can't-miss diagnosis.
Okay, so manometry confirms the diagnosis. But it does more than that. It also helps us classify which type of achalasia we're dealing with, using what's called the Chicago classification.
So there are three main types here. Type 1 is your classic achalasia. The esophagus is just a floppy, unpressurized tube. Then you've got type 2, which is actually the most common. In type 2, pressure builds up along the entire esophagus with each swallow. And interestingly, this type responds the best to treatment, probably because that trapped pressure helps shoot the food through once you finally get the LES open. And then there's type 3, or spastic achalasia. This one's characterized by these chaotic, premature contractions. It can be the trickiest one to treat.
And here is the absolute key point. Why this classification matters so much. It's not just some academic exercise. The type of achalasia is the single most important factor we have for predicting who is going to respond to which treatment. It literally guides our therapy.
Which brings us right to the treatment algorithm. Okay, we've got the diagnosis, we've got the type. What are we actually going to do about it? You can kind of think about the options in a few different tiers. Way down at the bottom, you've got medical therapies like nitrates. They're really just for temporary relief in people who can't get other treatments. A step up from that is injecting Botox right into the LES. But again, that's temporary, it wears off. So the real mainstays, the definitive treatments, are things like pneumatic dilation, where you use a balloon to basically stretch and rip the muscle fibers, and myotomy, which means we're actually going in and cutting the muscle.
So when we talk about myotomy, there are two main flavors. The traditional one is the Heller myotomy, a laparoscopic surgery. But the newer and frankly game-changing technique is called POEM. That's peroral endoscopic myotomy. Here the entire procedure is done with an endoscope from inside the esophagus. Now here's the crucial link back to our classification. POEM is now the go-to preferred treatment for type 3 spastic achalasia. Why? because the endoscopist can cut the muscle much further up the esophagus, disrupting all those chaotic spastic contractions in a way that surgery just can't. Hey, quick pause here for a high-yield number. You need to burn this into your brain for your exams and for when you're consenting patients. The risk of esophageal perforation during a pneumatic dilation is about 2%. It's a known, significant risk you just have to be aware of. 2%. Got it?
All right, let's bring it all home. Time for the key takeaways. What are the absolute must-know facts that you need to have locked in for the wards and boards?
Okay, let's do a rapid-fire review. 1. The classic symptom is dysphagia to both solids and liquids. If you remember one thing, remember that. 2. You always get an EGD to rule out pseudoachalasia, especially if there are any red flag symptoms. 3. High-resolution manometry is the gold standard. It diagnoses and classifies. 4. Treatment is tailored to the Chicago classification, and POEM is the winner for type 3. And finally, number 5, after you fix the blockage, the most common problem you have to deal with long-term is acid reflux, or GERD. And that actually leads us to our final thought-provoking question. So, you've done a POEM, it was a success, the patient can swallow again, fantastic. But now they have terrible, debilitating reflux that isn't getting better with any medications. What's next? Well, this is where the field keeps advancing. There are now emerging endoscopic procedures designed to tackle this exact problem, like a transoral incisionless fundoplication, or TIF procedure. It's a perfect example of how in medicine, our solutions often create new challenges we then have to innovate to solve. Thanks for listening.